Hi everyone and welcome back to the Byolete podcast, the podcast where we discuss the science behind the brand. In this episode we're going to be discussing something that our listeners may never have heard of, and that is Lp(a). Lp(a) is a biomarker that we offer at Byolete, and it also has very strong correlations with cardiovascular risk, and therefore we thought it would be good to just give you an introduction into what it actually is. So this is a very late podcast that we're doing today. It's Sunday and it's about 10 p.m. But we've had a busy weekend again. I've been at a hen do this weekend for one of my friends, so the wedding is in approximately, I think it's like 4 or 5 weeks, that's really exciting. So we're going over to Madrid, aren't we, to celebrate their wedding, which will be very nice. And so I had a little bit of a late night last night in terms of got home about 12 o'clock.
You came late tonight.
Oh yeah,
up at 12:30.
You got me 12:30 from town. I went to something called Bongo's Bingo. If anyone's listening from the UK, you'll probably know what that is. And yeah, it was really good. Didn't win anything, but we had a really nice night.
That's good. And then I think last week we said we were going to do hot and cold therapy again. I'm going to stop saying what we're going to be doing the next week because we never do it. We're picking Lp(a) today because I don't even know why we're doing it. I think we've come across a few studies recently and more of it's gaining a bit more traction.
Yeah, and I think really when we decide on what we're doing is based on what we discussed that week, and sometimes things will come up and like you say, I think one of us must have read something and we're going, oh, actually, let's just go and discuss that, because I was thinking about it today that we haven't done this topic yet.
No.
And like you say, it's gaining more traction. We're offering it as a biomarker at Byolete, and so, we thought that it was just important to, like I say at the beginning, just really give a basic introduction, just a very quick overview of what it is so that people are aware of it. Because like I said before, I don't know whether most people probably won't be aware of this biomarker.
I mean, I wasn't aware of it until we started looking into it.
Yeah.
It was never anything that we would listen to, that we learned in university, and nothing that we applied in hospital or even primary care, GP land.
No. On that note, though, I have actually seen a couple of lipid clinics, so specialist clinics who deal with people with high cholesterol, checking Lp(a) levels. But I've only seen about a couple over the last 12 months. So, like you say, it's gaining traction, but we're still not there yet. But it is an important one that we do check, because, like I say, it is an independent risk factor for cardiovascular disease if you do have high levels.
Yeah.
So, do you want to get into them? What it is? So, what does it stand for?
So it's Lp(a), so lipoprotein A.
Yes.
Now, if you've listened to any of the previous podcasts, cholesterol cannot go around your body unless it's attached to a vehicle.
Yeah.
Because if you put fat in water, it just doesn't disperse. Mm-hmm. So a lipoprotein is essentially that vehicle.
Yeah.
Now, people have heard of bad cholesterol, which is LDL cholesterol, and we've went into ApoB so many times on this podcast because the more I look into it, the more I'm intrigued by it. Mm-hmm. So every LDL cholesterol has an ApoB on the surface of it.
So it's a bit like a signal, like a marker, isn't it? That's the best way I describe it, where it's like the taxi sign on top of a taxi.
Yeah.
And so your body can recognise that is an ApoB.
Yeah. Yeah. So Lp(a) is then attached to some of these LDL cholesterol particles. Yeah. So it's not necessarily all of them that are going to have this bad genetic link, but it's going to be linked to some of them.
Yeah.
And what that does is it increases your risk of cardiovascular disease, meaning heart disease, stroke, by quite a significant amount. That's the big thing. Yeah.
So what I read was that this particle of Lp(a) that's attached to some LDL cholesterols makes it more sticky. So it's probably not the best way, scientific way to describe it, but it means that it adheres to your blood vessel walls a lot easier than what an LDL cholesterol with just an ApoB particle on it would. Obviously, there is some nuance to that, but that's a general overview of sort of why it is associated with an increased risk, because it can stick to your artery walls. It also sort of damage them, cause the inflammatory cascade, which then increases the risk of plaques forming within the artery walls, isn't it? So the LDL cholesterol with the Lp(a) particle on it can stick to them more easily. Is that a good way to describe it?
I mean, without going into too much
Yeah.
detail, yeah. But it does become more complicated, doesn't it? That there's so many things attached to cholesterol. So we come out of university, we thought cholesterol's cholesterol and that's it. There's so
you
many
had good
things.
and you had bad, and then you wanted to increase your good and decrease your bad when, like you say, when we've looked into it, it doesn't always work like that.
Yeah.
So you just mentioned that it was a genetic, or you mentioned genetic when you were talking about LPA.
Yeah.
So I think it's important to point that out, that
it is a high genetic risk. Now, apparently this was looked at back in the 60s, 70s, and then the data that come out didn't link it to any increased risk of heart disease or stroke.
Okay.
So it was only recent, I think it was the late 90s, early noughties, where they actually found that the assays, so the blood tests that they were doing, weren't representative of LPA. And then that's when they started to see this increased risk, and it was causally related to cardiovascular disease.
Okay.
And that's why it's gained a lot of traction over the last decade. And I was looking into who does it affect more. So it's meant to affect the Chinese and Japanese heritage less.
Yes.
And Black African.
Yeah.
Or Afro-Caribbean origin to greater levels.
Yeah. I did read, where you can correct me on this, that a lot of the studies are done in Caucasian.
I think a lot of studies in general are, unless you...
Again, it could be that, okay, there is a high level or there is a high incidence in the Black Afro-Caribbean population, but they may not be affected as much, but we wouldn't know unless we did tests on them. And I think, from what I read, because it is such an evolving science, I don't think that a lot of the studies are. So, you know, that's definitely something that we probably will figure out over the next 10, 20 years.
Yeah, and in terms of the genetics, everyone has the LPA gene.
Yes.
So there's an LPA gene which makes the LP(a) protein.
Yes.
Which is then the one that attaches to the LDL cholesterol.
Yeah.
VLDL. When I say the LDL, it sounds like D.
V.
So THE, VLDL. Yeah.
Okay. And I think that's a good point, because I always like to think about things in a way where I think, well, what is the evolutionary purpose of a specific thing? So I always get intrigued by that, because obviously whenever we've evolved, obviously the body is an unbelievable machine, and things are there for almost always for a specific reason. So I just was looking into very briefly what it was for, and so I think they were thinking it was to do with repair of sort of, I think when you think about our ancestors, they were doing a lot of foraging, they were doing a lot of hunting, and so even things like, you know, walking through a woodland and you're getting cut by leaves and twigs, and, you know, we don't do that anymore, and so we don't really need LPA anymore, from what I've read, although I will get onto a little bit more of that. I read about that in a sec. But yeah, I think it was to do with the fact that it aided repair of damaged cells, of tissues. So that was why it is around, and why we do have a gene to produce this molecule.
Yeah, so what I read was because it's so closely linked with plasminogen.
Okay, yes.
So the gene, or the placement and where the gene is, whatever you want to go into, it's so closely aligned with plasminogen. Now, plasminogen, I've got to go back into this now. So plasminogen is a precursor to what would break down a clot within the body. So plasminogen goes to plasmin, which then breaks down clots within the body. Now, it duplicated that gene, which is LPA.
Right, okay.
So if you have LPA, this is another reason why it's so bad, is because it competes with plasminogen. So if you've got less plasminogen being converted to plasmin, your body's in a thrombotic state.
Right, okay.
It doesn't want to break down a clot.
Right, okay.
LPA is competing with that pathway.
Okay. Okay.
So that's another bad thing. So you've got all the bad thing in terms of it being stickier, it's got a higher ability to oxidize, lead to plaques, and then you've got this idea that it doesn't allow clots within your body to break down as effectively, or that thrombotic state. It's going to increase your risk of heart disease and stroke.
Right.
But that's where I think, so that's where it lines up with trauma, is it's so closely related to that.
Okay. To basically form clots.
That's...
To sort of, if you were bleeding or whatever, then it comes to the site of the bleeding.
That's what I read anyway. How true it is, I don't know.
Okay. And I guess maybe the reason why there was 2 genes for it and it duplicated it was because of the increased risk years ago that there was
there's so many things through the genetic. I think there's 2,000 variations. Again, this is something that we need to look into a lot more. We know the reference ranges, which we'll go through quickly in a minute. We know when to test to a greater degree now, but in terms of the pathophysiology and what's going wrong, there's so much into it that, I actually realised that I don't know that much about it.
Yeah.
ApoB and all them things I'm quite good at now, but LPA I didn't know too much about.
Because then what I wanted to get onto, just again very briefly, because I only read it very briefly, but it was saying that LPA could have anti-cancer properties.
Okay.
To do with the fact that it slows down the growth of extra blood vessels. So if you think about cancer as a disease, usually it has a very good blood supply, and it it produces all these extra blood vessels in order to feed the growth, whereas LPA actually reduces that. So again, it's this balance, I think, in nature all of the time, where we have to balance it not being too high to cause cardiovascular risk, but then not be too low that it doesn't have all the extra properties of obviously helping repair tissues, but also maybe anti-cancer properties. And again, because we don't know too much about it, I think it's going to be one of those things that will be evolving over the next couple of decades to see what we should do. And I think that's also an important point with cholesterol in general, because we do discuss a lot of the time on this podcast that get your levels down to like really, really, really low, or as low as you possibly can. But it is important to note that we also do need cholesterol, so it can't be that we have a cholesterol level of 0, because we do need it to for normal function, for every cell membrane. Our brain uses cholesterol a lot, and so it's a balance, like everything is in medicine, in science, in nature, where you try and weigh up the risk versus the benefit.
Yeah. But the difference now is that because the population as an average is becoming so unwell and sick, that we're allowing people to have a normal result within a sick population. And that's why we need to lower it aggressively, because years ago that wouldn't have existed. But going on to the next thing, why did we bring up genetics? So this is related to how often should you test. Now, they believe that once you get to the age of 2, you've already developed a set amount of LPA. So then in terms of if you got tested from the age of 2,
it would always remain the same.
It's going to be
about the same.
It's not going to be changing too dramatically. So that's the whole point. But in America, I think, so Canada, by the looks of it, looks like they're leading in LPA. So it goes Canada, the US, then us. I think anyway, that's my opinion. But when I looked at some studies, they were saying Canada's doing this as a preventative thing. The US are doing it basically once you've got the disease. So if you've got heart disease at 40, why have you got that? Oh, your LPA is high. Whereas in Canada, they're doing it early, and now we're only doing it through specialist clinic referrals to lipid clinics.
Like we said at the beginning.
So we are doing it, but at least test once in your lifetime to see where you're at. I think that's a good point. And that's what we've got at the moment. That's what we're sort of advising.
So I have a couple of points. First off, do you know how old they were in Canada when they were testing them? Was it at a young age, or was it in the adult population? Because I always think, well, if at 2, a child has produced or they'll have the LPA level that they'll always have, wouldn't it be a good idea to sort of test within childhood, because you then know what that child's risk is, and so the parents would then know, okay, well, my child could potentially be at an increased risk, because like we know, it's sort of the level of ApoB over the whole lifetime is what contributes to your cardiovascular risk, rather than
a snapshot.
A snapshot, yeah.
It's always the area under the curve, isn't it? It's not how much you've got at one point, it's how long you've had that for,
which
cumulatively.
So if you were to test the child at that age, although it's only one part of the picture, at least okay, well, this is something that I can definitely,
I know what you're saying. You can nurture
your child differently, maybe, if you had the option, whereas if you're not testing, then you would never know.
But I think the difference is, and the complexity is, that LPA testing's become more advanced, but I still don't think they've nailed it down. So in America, they like to use milligrams per deciliter for a lot of things. In the UK, we like to use molar weight, so moles per litre. And I think in America, they're trying to shift towards this moles, because that tells you how many molecules there are as opposed to weight. There's so many different forms within LPA. There's loads of different isoforms. They're still trying to determine, is it the mass of something or the number of particles? So in terms of, we now know LDL cholesterol as a mass doesn't really tell us too much, whereas ApoB tells us how many particles, it's more effective. So I think it's all down to, they are actually looking into pediatrics, and I did see a couple of the studies. I just didn't go into them because I thought that's for another day. This is too late, but it's a good point. But at least once in your lifetime, I would advise, especially if you've got a risk of people within your family having heart disease, strokes, but before the age of 40, definitely. Even before 50, you'd probably look into it.
Yeah. I think as well, like the reason why you say once in your lifetime is that at this moment in time, there is nothing that we have that can lower it. So, I mean, to a degree where it would make a huge difference. So it's all about mitigating all of the other risks that you might have. So hypertension, smoking, insulin resistance, lowering that ApoB level. Because at the moment we don't have anything that would really significantly reduce LPA. There are medications in the pipeline. I think there's a couple in phase 3 trials, so we might see them being brought out over the next couple of years, which are targeting RNA. So they're actually targeting the production of LPA in the liver.
Yeah.
Which is, because I think they're not really sure about the catabolism of LPA. I was reading where it's very difficult for them to have
what initiates it.
Yeah.
It happens within the liver. Well, deem it to be, and a little in the kidney, but in terms of what initiates it, they're not too sure. But yeah, so what are they? Illegal nucleotides is one of them. And then the ones that we've got at the moment, statins, we put people on a lot of statins for a lot of things. It will lower your cardiovascular risk or burden, but whether it targets LPA directly, it doesn't seem to be, but it will still reduce your risk. So always go on them if you can.
Yeah.
The ones that we want to discuss are PCSK9 inhibitors because that's increasing the receptor on the liver.
Yeah.
They have an effective or efficacy of 20 to 30%.
Yeah.
But this is the thing, when you actually look at the results and what reference ranges we should be going for, that's not agreed anyway. Again, so it's making it harder again. Yeah. So in the UK, we're saying anything less than 75 nanomoles per litre, which is about, again, trying to find the conversion from nanomoles per litre to milligrams. They change it in terms of ratio, but that's give or take less than 30 milligrams per decilitre if you are in the US or Canada. And then they say your risk is okay up until 50 milligrams per decilitre, which is 125 nanomoles per litre.
Right, okay.
And then once you start getting a bit north of that, I think the EU, especially Germany, cut out a treatment where you're not eligible for it anymore.
Right, okay.
On insurance.
Oh, okay.
I think it's called apheresis.
Oh.
So basically it's like dialysis, but for cholesterol.
Oh.
It's got a 75% effectiveness.
Oh, wow. I've never even heard of it.
I didn't look at it. So I was like, it says 30 milligrams per decilitre, less than that's ideal. 50 and below is still, I think it's where the EU or EAS, the European Atherosclerosis Society, I think, they advise less than 50. And then when I got to 60, it said, this is where payouts from insurance for countries such as Germany for apheresis ends. And I looked at it and basically it takes your blood out, like dialysis, filters your blood and takes out the LPA and puts it back in, and it's got a 75% efficacy.
Oh, wow.
I need to look into it more, but that's what I had a quick glance over.
Completely takes it out, or just like takes it out to a ratio? Okay, that's cool.
I don't know, but I just seen it and I was wondering why it was on a graph. That's why I looked into it.
I think, I say it all the time, but the more and more you look into things, the more and more you realise that, oh my God, I haven't even scratched the surface for like medicine.
When I look up, when I started in hospital, definitely didn't look into it in this much detail. Then I started in a GP surgery in March 21, and you would literally look at the cholesterol profile and go, oh, that's high.
Yeah.
Oh, that's low. Oh, let's maybe put them on some medication. And that was it.
Yeah.
There was no other insights. And when there's so many things that if you've got high LPA or you're an oversynthesizer or an overabsorber, it completely change how you would approach a patient.
I mean, I was speaking to you about this before, where I said I had 2 patients who have been on statins now. This was just in the last 2 weeks, actually, and the dose has been titrated up to the maximum dose. So I think atorvastatin 80 is what they're both on. One of them is a young lad, one of them was an older man, and the LDL has not changed. So despite whatever dose they've been on, there's been no improvement in it. So initially I thought, okay, well, it could be that they're not compliant with the medication, which I do need to check, but it could be the fact that they do have high LPA levels, which we would never know. And so maybe it would be a good idea to get them referred to the lipid clinic, because if we're not seeing any improvement, it might just be, okay, we'll check an LPA level, maybe even do an ApoB level to see what the risk is of, cardiovascular disease, and then take it from there.
and we don't have access to stuff like the Boston Heart Health blood test either, which is telling you whether you absorb more than what you synthesize, which again would change how you approach it. You'd give ezetimibe over a statin.
Yeah. It's so interesting. But I'm so glad that we have been looking into it, because I think, like you say, it does change your practice and you do think about other things. And I do think that all of the sort of stuff that we've been talking about, like ApoB and LPA, it will be adopted by the NHS at some point in the future. And we will know a little bit about it. You know, and it does allow you to see your patients in a different way. And maybe, although the resources may not be there fully yet to support, you know, the stuff that we've been going through, at least you can even give patients an insight. Like, it may not be this, but it could be, like, maybe just go and have a look at it and try and mitigate your risk until we have the option available to make an intervention. So it is really interesting.
Yeah. I mean, it was a whistle-stop tour, but it wasn't, because we still managed to speak for quite a bit of time.
I know.
But it is all interesting, isn't it? And I think we've got to go into this in a bit more detail. There's so many things I've not looked at. There's so much I don't know about it. I know the ranges. I know how to interpret a lot of it, but I want to know a lot more than what I do.
Yeah.
So I'm not going to guarantee what we're going to be doing next week, depending on what patients we come across.
Yeah.
How we read certain studies. If anything else pops up, it's all related to heart health anyway. That's the main thing.
Yeah.
That's all I can guarantee.
Yeah, that's what But as always, thank you for watching or listening, and whatever platform you are on. If you haven't already, then please like and subscribe to this channel, because it really helps us. And yeah, if you have anyone who you think might benefit from actually listening to this podcast, then please send it to them. And as always, we'll catch you at the next one.